Good morning, everybody, and welcome to the 21st meeting of the Equalities and Human Rights Committee. Can I ask everyone to ensure that all mobile devices are switched off and put away? This morning we have apologies from Angela Constance and Annie Wells. Agenda item 1 is Female Genital Mutilation Protection and Guidance Scotland Bill. I'd like to welcome our first panel. This morning we have Esther Kumanji from Kenyan Women in Scotland Association, Girijambo Pulubuthu, Manager, Shakti Women's Aid, and Sarah McAfee, Violence Against Women Development Officer, Amina Muslim Women's Resource Centre. You're all very welcome this morning. Thanks for being with us. And can I ask you to tell us a bit about your experience or knowledge of FGM and the work that you do in relation to it, and then telling us that whether you support the aims to strengthen the existing legal protection, please. Sarah, I'll come to you first.
So Amina has a helpline where we offer support for women who might call us for any reason, including because they may have a concern about FGM or may have experienced it themselves. My role involves training with our staff and volunteers, including on FGM and related issues, but it also involves awareness raising within the communities we work within. That would be either in women's groups, where I might lead a session where we would talk about violence against women and girls in general and include FGM as part of that, so it's not kind of off to one side as a sort of stigmatised issue. It might involve men's work, so we work with sheikhs and imams, and we have a film that we show with men's groups where imams and sheikhs talk about FGM and the position on that within Islam. And we also have campaigning and sort of like blogging and social media input. So by doing that, we're kind of correcting attitudes more widely than the folk that we actually have time to reach out to, and obviously also contributing to policy locally and nationally as well.
Hi. We are domestic abuse services, and we support all forms of domestic abuse, which includes FGM, forced marriage, dowry-related abuse. And our role is we are actively involved in campaigns of FGM, forced marriage, and other honor-based violence. And we have we've been supporting women from the countries where FGM is practiced, saying that the women that we support, for them the FGM has already happened and they have migrated to the country. But recently we also have cases where the mothers are fleeing domestic abuse, but there is an element of fear of FGM happening to their children. We currently have about 5 cases, one mother with 3 children, and one single person and another one with children. But the mother with the 3, is it okay to say that one is FGM has already happened in Europe, and she fled from there to prevent any further harms. So these are the types of cases that we support. But what we want, the support that we also give is like any other domestic abuse cases, we support the women to get access to accommodation, financial access like benefits and all. And if there is any immigration issues or asylum seeking issues, we help the women and the children to get those the immigration sorted. And we support her if a woman or a child discloses of FGM happening, then we support the women to access the protection orders, and we do work with the police and the social work quite closely. Yeah.
Esther, could you say a bit about your organisation, about Quisa, please?
Thank you very much. Sorry for being late. Our work is focused mainly on, based on African women. I'll just give the context as a whole. Most of the people who we work with and associate with in terms of FGM, they really come from African continent and its diaspora, and also many of them come from the affected area. To give a historical context of KWISA, or Kenyan Women in African Association, just very briefly, how we came into being, first of all. FGM is not, has not been forced. We were not the first one to fight FGM. How, in Scotland, we find that the bill, which was first put up on 2005, there's a lady called Khadija Cole, who is still very active today, who really fought until that bill came into being. And I'll tell you where I'm going with this. And then thereafter, about 2002, Akina Mama of our Africa, which was a Scottish African women who came together then, 2002, really worked on FGM, talked about it, and even thereafter had training. Akina Mama of Africa now has become an international organization. Their head office is in Kampala. Thereafter, many people, over the years, many people have became experts of FGM, and at one point it became very, everybody was talking about it and doing it. But within the community, people were getting very disgruntled, and in 2013, we decided to come together and just address the issue, because our voices, our faces were not being seen in the face of FGM. Everybody else was in the pot, but our fingers were not there, but we were just being dished the food, as we say. So 2014, we had, KWISA had a seminar at Linithgo with Assistant of West Lothian, and we had 80 women who came there from 14 different countries. You notice that KWISA said Kenyan Women in Scotland, but we had to register some organization, because if you're not registered, then you're not known. But that tells you that all these women were involved in fighting against FGM in one way or another, but because we didn't have a sort of a platform. So that's how we came together. It was very clear from that meeting, that seminar, we both cried and laughed at the same time, but it was very clear that we needed to have our voices in the front. We needed to really give the context and contextualize how the FGM was being discussed at that particular time. And the issues were everybody else was an expert, the language which was being used, and we were just being token to the whole discussion, but not being part of the discussion. Rather, people talked about us, but without us. And that's the way we felt. And all those women who came that day. One thing which was clear was that we needed to raise more awareness, we needed to talk among ourselves, and we needed to be involved with the other people. So, having said that, so KWISA from then, 1 year women tried to come together on a voluntary basis, but it couldn't work because of various commitment, and it was on a voluntary basis. So African Women Against FGM was formed, but with the recommendation for 1 year having worked that we really needed to formalize it properly and move forward. So later on, we became African Women Against FGM, and we were funded by Scottish Government, 20,000 grant, which really propelled us to start off the project. Our approach, which I'll be able to give you our model later on, you keep it. I'll say KWISA engagement models as opposed to the traditional engagement model which is used, especially in policy making and the process as a whole. When you find that when we are making policy, we start with the policy agenda, and then we move on to analyze and look at the risk assessment, formulate the policy, consultation, and then implementation. But as far as we started with the community issue, and that's where we start. This is a concept which has been used in many countries and in many places. So our community issue at this particular time is FGM, but within the context of very other things, analyze, prioritize it, then go into the community learning issues. I'm just going quickly, and looking at the skills and development, and then looking at the delivery of services which we have around us and influence and change, and then of course change of behavior, which is what we are looking at. And in all these contexts, we started with the women, but of course we've worked with all the stakeholders, but really the community is the main stakeholder. And from a point that we are insiders, some of us have gone through the FGM practice itself, we know the context. And to avoid a single story, which was being told then that FGM is only one type, and mostly it was the cutting which was being narrated. But there's a lot to it than that. And as we say, FGM is just not cutting. There is more to that than FGM, looking at the holistic picture of what happens, engaging the men, engaging the women, engaging the faith leaders, which is very critical when it comes to FGM, engaging the service delivery organization, especially social worker and NHS, which we've managed to work with.
Just pause you for a minute, if that's okay. I think many of the things that you're saying about what's happened in the past are going to be relevant to what we're doing now as well. And I hope that the questions from the panel will draw out some more of your experience in that. Can I ask panel members their view on the existing legal framework and whether you think that the approaches that we have at our hands at the moment are being used effectively, and if not, why not? Sarah.
Yes, I think, sorry, got a bit of a tickly cough. I think that the existing legislation describes FGM quite well. I think that it would be ill-advised to adopt new language, as was in the consultation, without thinking through what that language is. And again, like Esther says, consulting with practicing communities very extensively, because some of the language was quite inaccurate, such as vaginal elongation, which isn't a thing. So I think that the existing one is quite clear, and it covers things like labial stretching in type 4. So I think it's sufficient in terms of how it describes FGM. I think that the issues are around, we haven't had prosecutions, obviously, and it's looking at whether it's about supporting the women and girls who've already experienced it, as well as criminalising what might happen that we may not be able to capture. So as things stand, the protection orders might fill that gap in terms of prevention rather than criminalising retrospectively.
Thank you. Does anyone want to comment on the existing?
Sarah has said, I agree with most of it, but also we were discussing just outside. Some of the things for us is, like even Esther mentioned, like, the use of language when you describe an FGM, and also to demonize the community where this practice is coming seems to be a problem for us. There is a way that you actually can do it better. The bill is good, but there's in the sense, like Esther said, you work with the community, find the words that describes FGM. For example, some of the women that we support, they don't like mutilation. They rather prefer cutting rather than mutilation. And sometimes I think we kind of push the communities away by the language that we use, because they're then on defensive side, because this is a practice they've been used to, and it's just passed on from generations to generation. And I'm sure nobody even thought about it, whether it's against human rights or anything else. So for us, I think our role is to work with the communities whilst we are supporting the survivors of FGM. And the bill is quite good, but one more thing can I mention? Where again there's a problem that sometimes we had cases where the men are using FGM to prevent the women from visiting her families where there's domestic abuse. As you know, we support cases of domestic abuse. So there was a case where it's to do with death of a family member, but the woman couldn't go.
Just to be clear, are you saying that abusive partners are using as an excuse to prevent them to travel?
Yeah, if she
Okay.
want to visit a family, what they're saying, no, and especially when they have the female children, what they're saying is this woman is going, and there's a fear of she's going to, perform
Okay.
FGM. So that actually creates a problem. It doesn't, it does, that's not the intention of the women, but it's used. So I
Okay.
just want to
Thank
say
you, that's important. Yeah,
that's
that's really helpful. You had a supplementary, Alex.
Thank you, Convener. Just very brief supplementary, but I'll come back in later with other questions. Can I just say, Inger and Jamba, that is a really interesting point that we'd not heard before, I'd not heard before, and I'd like to explore how we deal with that, perhaps even in guidance behind the bill. Just further to the convener's question, we had quite powerful evidence last week around the dangers of racial profiling in this bill and stereotyping and creating a legislative framework which unnecessarily prejudices a community. We're very sensitive to that, very sensitive indeed. So the same person suggested that existing child protection guidance or legislation would be sufficient to protect young girls in this situation. Can I ask if you would agree with that?
Sometimes actually when we get calls asking for our advice in such cases, we simply say, I'm not a lawyer, so I really don't want to comment on something that I'm not an expert in. But what for me, as a woman and as a general a domestic abuse worker, sometimes we are so frustrated where people come and say this child is either at risk of FGM or at risk of forced marriage, and they're more concentrating on the culture, more concentrating whether we'll offend the community or not, rather than, in those cases, what we advise is, if it is a mainstream child, if it's a Scottish child, and if you feel that there is something, harm is going to happen, what would you do? You would use child protection order. So in those cases, just think that way rather than finding barriers to say, oh, that maybe I'll offend them, this is their cultural thing, and you get entangled in that discussion. So I think you need both for me. You need both. Sometimes you may have to use the child protection order.
I don't oppose the introduction of this bill because
It's good to have
it's
it.
good to have the bill
We
on
actually-
top of the child
we
protection.
support the bill. I want to make it clear. We
Thank you.
support the bill.
Yes.
I'll agree with her. I think both needs to be there, the child protection and the bill. And definitely, while of course we get entangled in the culture because everybody has the fear of being racial profiling, it's important to name the issue or the problem, and then we can frame it adequately. I think that's, yeah, both of them are important.
Okay, thank you very much. Fulton McGregor.
Thanks very much, Convener. Good morning, panel. And it's probably, actually just moving on from Alex Cole-Hamilton's question there about the child protection procedures. Obviously, part of that, a big part of that is a children's hearing system. And one of the questions that we've asked previous panels is for thoughts on whether you believe that children's, it's not included in the bill as it's drafted, but if you think that the children's hearing system should be able to make an order.
That
The children's hearing system, if the children's hearing system would be able to make an FGM order. What's your thoughts on that?
I'm not so sure, but I think it should still stay in the children hearing system because most of the people who undergo FGM are underage. Well, there are issues where some adults also are undertaken, women maybe after marriage or for whatever reason, but most of it is children. They're below the age, so we should handle them like every other child. I believe that's what we believe. Yeah.
So maybe if I rephrase the question, because I probably didn't put it very helpfully. So at the present time, the children's hearing system can obviously implement legal orders for children who are at risk of, in need of protection. And you mentioned that there in the question to Alex Cole-Hamilton, but the bill proposes that it's a court that would make an FGM order, and a children's hearing wouldn't have the power to do that. However, a court could refer it back to children's hearing. I suppose what I'm trying to get from you is if you think it would be helpful if the children's hearing system would also have that power, or if you feel it would be best placed being at court.
One thing there might be looking at how the forced marriage orders are currently being implemented. Obviously, that's something that can affect adults as well as children, but certainly since they came into being, it's sometimes been felt that there aren't enough bodies that can ask for an order, and maybe widening that to another body with expertise could even be trialled. It doesn't necessarily have to be a black and white thing. As we tend to support adults rather than children, we don't have specific expertise on children's hearings. But definitely in terms of how this bill is going to be put into place, I think looking at how forced marriage orders have been used is really helpful, and also how they're being monitored, if that makes sense.
Okay.
Again, I don't have, although we have children's services, but I don't know much about how the children's hearing actually work. And that's why I don't want to comment on something that I don't know. But like Sarah says, it's better to widen the number of people that actually can take these orders. Similar, like for example, the forced marriage now is extended to the police, which we really support that. So, yeah.
To what you were saying as well, that why would we treat these girls differently to other girls with a
That's
concern we have about?
our argument is that you should treat these children same as you treat a Scottish child who might be at harm from their parents because of their drug addiction or anything. It's similar to that. If a child is at risk from FGM, that's their family thing, and you have to treat it the same.
Thank you. Fulton View.
Perhaps moving on to a wee bit more of a wider question, what do you think as a panel the impact of FGM protection orders will be overall? What's your thoughts on what the impact will be? And do you think there will be a need for training across various agencies and bodies?
I think for us, what we find is whenever a legislation is passed on, and of course there's more awareness about that subject in public, as a result of that, the demand or the disclosures or reporting might increase. But then what happens is when it's reported, there are no services to support these the survivors. That's something that the Scottish Government have to look into. Whenever you pass a legislation, you also have to look at it, okay, the legislation is good, but how then we will support the reporting survivors, whoever reports. Can you repeat the question, please? I want to say one. Training, again. It's a very complex subject. And I think the best people actually, you have to partner with people who come from the practicing countries. You might be a service, we are a service, and we have service users, we consult, we have workers who do, so we are quite confident in our training because we can actually, there are some questions that unless you come from that community, you're not able to answer in your training. And we do training, and I know that I've been doing training, and there are some questions, but at the same time, I again want to repeat, one thing we don't want to see is demonizing the communities. That I don't want to see, because this is something, it's been there, it's a practice, and we want to work with the communities, with the survivors, to eradicate the bad practice.
I think I do agree with you. Definitely there will be the need for training, there will be need for informing everybody, including the community, the practitioners, the service providers, and because it's a new thing, not a new, but slightly it's added value to the previous bills, whatever. However, when we come to the training, it's really critical what she has just said. I'm just going to add on to that. The reason partly why QISA came into being is because everybody was training by then, 2014, 2013, 2014, there was a huge a number of people training, and they've been training. But that I remember even we discussed it another day in the NAP, that there is need for standardization, there is need for the language, there is need for understanding, and there is need to involve the communities, because it's not a single story. There is a lot of diversity and reasons why people do FGM, and it's done for various reasons. So, and also the context and in which the training is done will either offend the community or individuals in the community, or will allow them to take it up. I'll give you an example. One of my housemates at one time, she's gone back to South Africa. She is a South African. She knew I was involved in a lot of FGM and community work. She did go into a training one time somewhere in Edinburgh, I don't know where. She doesn't come from a practicing community, but she's a mature woman, and she was there seated. And but in this group, there were men and women who were seated together, and there was a young person who was doing training. Excellent, knows everything, because the person is a nurse, and very highly qualified nurse. She understood everything, but when she came out of the training, what she came home very raging, told me, Esther, this is your FGM. Do you actually go out there to tell people to look at the African woman, how they look at like? And I was like, what do you mean? She said, I'm upset because, remember, on a normal circumstance, FGM, even within the communities, people don't even know what is happening within the communities. And here you are, you're being exposed. She told me, I felt like they're telling people, just when you meet an African woman, just expose her and check. So this is somebody who is very well versed with the program, with trainings, with issues. And if she came out feeling like that, how about the person who has absolutely no idea of what's going on? So that's just my take. So there is need to be very careful how we do it. We need to partner with the communities, and so that we can standardize, so that we can speak the language and support what is already there on the ground. And that's why I talked about the history, which the women who are still in this country since 2005 been working on these programs, but we're still talking about the same things today, 2019.
Yep.
My specialty is training, and you'll have to tell me to stop when I've talked too much. I think one of the things as a white Scottish person is just, this isn't something that one community is doing far away from us and our relationship with those communities. And we have a long history of, first of all, as white Westerners, fetishizing sub-Saharan African women. You know, you can look at what happened with Saartjie Baartman and the way that she was treated and exposed, and the way that particularly her genitals were made a feature of her identity in the way that other women do not experience, but also the way that we've exported sort of Victorian colonial attitudes to countries, and seeing those attitudes reflected back reflects on us more than it does on those communities. And also, I think that when we talk with women and men from practicing communities, one of the big concerns is that it becomes their whole story. So these are people who don't necessarily have a platform, who don't necessarily have access to tell the stories of their achievements and of themselves as human beings. And in effect, the first thing that somebody might assume about a person is that they are from a community that practices FGM. And it's not something that necessarily respects geographical boundaries. You can't assume because somebody's from a certain country that they've experienced it. And you certainly can't assume that they approve of it or otherwise without having, you know, a gentle conversation around attitudes. I think sometimes even health professionals might just demonstrate that a little knowledge is a dangerous thing by assuming somebody who looks like they might be from sub-Saharan African origin has experienced FGM, or other examples might be that they have sickle cell anemia when they're not remotely from the side of Africa where that's a thing. There's a lot of kind of, oh, you're from this place, and therefore this must affect you, and you must feel like this about it. And completely on the other side, not unpicking personal bias from the side of the white Western practitioner. I think giving training, it needs to be funded to the extent that it allows people to unpick that bias. Because if it's an e-learning, for example, where somebody is kind of rapidly reading through, maybe on their lunch break because they're really busy, you know, it doesn't go in the same way, and you don't necessarily notice your own bias in the same way that you would, even if you have a long history of reflective practice. There can be blind spots. So also in terms of training, there might be practitioners who are more able to attend a training, which is great, but there might be other people working in the area who don't necessarily have the ability to do that on a paid basis, for example, interpreters. So when the issues come up locally for us, one of the things that's happened, there's a general sense of panic sometimes, even though we have great harmful practices protocols, and I'm, you know, running around like a blue arse, whatever, doing training here and there, and there's other wonderful organisations doing the same. People panic. They don't necessarily look at the protocols. They sometimes push the responsibility onto third sector organisations, and then might even ask those organisations to provide interpreting, which is obviously a conflict of interest. It could also be a family member, which is, again, a massive conflict of interest. But even when you do have a paid interpreter, even when a family has been explained their rights in terms of accessing an interpreter, or when a social worker, for example, has organised one, interpreters don't always have the chance to debrief after a session, and they're paid sessionally, generally speaking, so they don't have the chance to attend training on a paid basis. So I think one of the things that would really help is to actually offer sessions where interpreters are somehow reimbursed, and where there are training organisations that are recognised as training to a gold standard, like what Esther was mentioning, not just, you know, anyone, but there should be some kind of way of centralising what we're meant to train when we train. And I think that goes for kind of all the VOG issues. I think that training should be in line with the values of Equally Safe, for example, and shouldn't just stigmatise one community. And the other thing I think would be really helpful is something like a training bursary. So I know women from practicing communities who I've co-facilitated training with, or who've helped me with creating materials for training because they haven't felt able to speak openly. But when I suggest to these women, because I'm, you know, trying to mentor women who seem really promising as trainers, you know, go to this, there's not a training budget for it. So they may be working in the area but not able to access funds. They may be developing expertise but not be able to kind of put that in a wider context because of the restrictions of working for a third sector or voluntary organisation. So some kind of budget to allow people who are already experts to give training might really help. And also some magical way of pressuring people from the courts to access training as well if they're actually going to be passing orders.
Thank you. Fulton.
One further question, Convener, and I'm aware of the time constraints. There was a wee bit of discussion earlier in terms of criminalisation. We got a wee bit of the views on that, I think, for a record, which is good. But I wonder if the panel were able to give the views on the penalties that's been set for the breach of an FGM protection order.
If you don't have a view on it, it's okay to just... No? Okay.
No, that's all right. Yes,
Okay, can I come to Alex?
Thank you very much, Convener. This taps into some of the questions we've had about the application of this law. Thinking about other laws of a similar kind that we've passed as a parliament before, and I think the most The clearest parallel can be drawn with the Sexual Offences Prevention Act, which created something called Risk of Sexual Harm Order, whereby it was a preventative measure that could be applied to protect potential victims from online grooming in that case. What we've discovered since, though, is that that was passed over 10 years ago, but the number of RSHOs which have been applied by courts can be measured on one hand. It's not to say that it's not happening and that children aren't at risk of sexual harm, but part of it is a lack of guidance to both police and judiciary and all of these other stakeholders. I just wonder, what additional measures do you think we need to do to make this act real so that it actually protects people and is used and not just allowed to wither on the vine?
Personally, it's important to have the protection and the support. If we just go criminal, it is not going to work. If we have the protection and we have the support of the person who is reporting or whatever, remember these things happen within the family, within the community, and therefore it doesn't matter if it's a community in Scotland or in London or in Africa, the people, and today with the WhatsApp, with the media, people will find out. So it is important for the community to understand, or the individuals to understand, that they're being supported through that process. At the moment, I think there's a lot of issues just around protection. So if a child comes and says, I'm being taken away, I'm going for FGM, what happens to my mother? Remember, this is done in love, but it's a crime at the same time. But do I want my mother to go in, or my uncle, or my auntie? You know, so we have to have protection and support system in place together. Again, example, FGM has been fought, especially in Kenya, since it's over 100 years. If you read Facing Mount Kenya by the first president, Mr. Jomo Kenyatta, we need to understand why do communities practice? Why is this practice there? Why has it been fought legally and not worked? It has been working in places where the communities themselves, and there are plenty of examples across the world that have taken the forefront, and therefore they are supported. So that, for me, the bill needs to have protection and support. If you don't have support, just...
Follow up on that, Esther. That's a very helpful answer. But my question is also about, do we need to ask the Scottish Government to provide money to properly train social work, police, the judiciary in understanding the issues around FGM, so that they know that they can use this arrow in their quiver, if you like, rather than just applying normal child protection?
Training is good and it's important to the practitioners, but where is the community in all that?
That's a very helpful question.
Because if the community is not there and giving their views and the way things are happening, and at this time, QISA works with, I'll tell you, QISA model is from the ground. We're just women who came together. We've been given this year 25,000 by the Scottish Government. That is helpful, but people work, it's me, I know people back home, I know here, and every woman over 15 countries now have something back in Africa and back here. So within their community, so it's a bubble and snowballing effect. And then that information is gathered together. If you really want it to happen, train the community, get them involved, get the leadership, especially the faith leaders. Faith leaders are really critical in all this, because people go to churches, people go to mosques, and also opinion leaders, and not just one person, because then you get a single story, like it's only cutting while we have 4 others. So yes, the practitioners train them, but get the communities also, so that you get the whole picture, so that people are talking to each other and you really know exactly the intrigues and intricate of the whole concept.
Thank you. That's really helpful. To make this, does anyone else want to come in on that question?
I just want to say that, you know, the training should be made mandatory for all like social work, police, anybody who is involved in supporting who may come across FGM cases. I think it should be made mandatory. And also, along with Esther mentioned about the communities, for me, it's very important that you work with the survivors, whether it's a historical FGM that is done elsewhere or here. It's very important to take their opinions and their ideas into training. And I agree with you that, to train, there should be money available to train the survivors to become trainers. Even if it's an input into a whole day training by a survivor, that would be really a good idea.
I think as well, it might be good to have some kind of awareness raising available to any MSPs who are speaking out about it, or anyone from policy within the Scottish Government, because there's been some language from politicians that's really, really unhelpful. For example, the word barbaric is very racially loaded. Even the word traumatic, which I'm picking up on quite a lot. I know we're all obsessed with language, but it really does, if you only have a couple of column inches to put this across, it paints quite a vivid picture of disgust at somebody who is a Scottish citizen, which is never appropriate. And the idea of calling it inherently traumatic doesn't really pick up on the fact that some survivors will use that word and some won't. And it doesn't really echo what we're hearing from women who've experienced it. So I think the way we put this across when it's implemented is just as important as the way that support bodies and statutory organisations use it in a way, because the awareness raising, that you get one shot at, like press releases and that kind of thing, and that will put it in the news and that will increase the need for support if it's done right, or just entrench sort of secrecy and stigma.
It's very helpful, if mildly terrifying, and to that end, I think I speak for the rest of the committee when I said if there is that feeling, I would really appreciate a submission, even like a glossary of the terms in terms of the language we use around here, which are racially charged or unhelpful, because we're doing our best, but we're operating, many different plates are spinning at any one time, and we might easily get that wrong. So please do make a submission just to help us, guide us through this process. Final question, convener. This bill will only be a success. And we will only fully eradicate the practice of FGM or the risk of FGM in this country if we adequately get to the girls that are most at risk of it, if we impart to them the reality that it's not right, that they have a choice, that they can be protected. But as we've discussed, a range of barriers, be that language, culture, family sometimes, mean that they are potentially further removed from society than other girls. How best can we communicate directly with those girls, and how can we get them to talk to each other about what's right and their right to protection?
I think there has to be, I think with any form of abuse, whether it's forced marriage, domestic abuse or FGM, I think we now have to start in schools, to talk about that. There has to be some kind of, maybe, I don't know, it has to be part and parcel of education. That way, it's not just about talking to the children from African communities. We want the mainstream children also to know about these things, because they are our future citizens, and they are the ones who will lead the country. You want to raise awareness with every child in this country. It's not just about the children who come from the practicing communities. I would say that, and like I said, in every form of abuse, that's what should happen.
I think I exactly agree with her. We need, looking at the way we've worked, of course QUISA started with the women, then men, women, and our last project, which we worked with the Glasgow Caledonia University, which is a research project with Glasgow Council, which of course ended after a year, unfortunately. We were working with the school children, and the beauty of the whole project, which was the energy which we saw in those children. I'm sure it's some of you who came to the conference on 6th February saw how those girls, the 6 weeks we worked with them and the impact of the information. Some of them have never heard about FGM, yet they're African children. Nobody talks about it in school. But it's not just FGM, because we cannot put FGM in isolation without talking about human rights, about all the other issues which go with it, because traditionally FGM is supposed to be sort of a passage of right of one kind or another. And therefore, if we need to have those programs in schools, but in a way that which will not stigmatize them, which I do agree with her, that everybody needs to talk about it. But really, the girls need to start knowing, because when they were asked to go and talk to their own families, that's when some of them opened up. But it's the knowledge, giving them the confidence, the aptitude, because it's not an issue which is talked about openly, and they will be able to. But having those programs, that's finished now, 1 year. So we've got to find our way working with it, and hopefully.
Very helpful.
Okay, I feel compelled to say that I think we probably would need more than a glossary to properly address our inherent bias that we would have. But I appreciate the thing, and do feel free to challenge us if there is language that we're using that isn't helpful. Can I move on to Mary Fee, please?
Thank you, Convener, and good morning, panel, and apologies for my voice. I have a couple of questions around guidance, which I'll ask as one, and then I have a specific question around training. The bill gives ministers the power to introduce statutory guidance. Do you agree that the guidance should be statutory and not advisory? And what do you think should be in both the general guidance and the specific guidance on the protection orders? Who would like to start?
I can only say that I did submit something to the original consultation, and it took me a wee while to think through and look at what was out there already and give a fully informed answer. So I can't really do it justice in the 5 minutes that we have left. But I do think that moving towards having statutory guidance might just lend a bit of credence to the fact that, you know, like we're saying, people actually need to take this on board and take it seriously.
I think just to add on to her, basically, I think it should be statutory guidance, but without going into the details of the merits. Basically, people need to see the seriousness on it as just being advised, and you can decide to take it or leave it. That's kind of thing I would say in terms of guidance. And training, what was it about training?
I'll come on to training in a moment. Girijami, did you have a view on the guidance?
We worked quite intensely with the post-marriage statutory guidance, and we had a lot of input into that. Looking at that, I think it's necessary to have the statutory guidelines, and I think the current ones you can strengthen those current guidelines. And for me, I think whether guidelines or no guidelines, I think it's responsibility. It's responsibility of every citizen in Scotland to prevent and protect survivors of FGM or any other forms of domestic violence. That's what I would say.
Okay, thank you. And my second question was around training, and perhaps if I could start with Sarah. There's already multi-agency guidance in existence around FGM. Is that something that you use as part of your training? And do you think that whatever statutory guidance is issued, or whatever guidance is issued with this bill, should be suitable to be used as part of a training process?
Yes to both. I highlight what laws exist, what guidance exists, and other resources like the FGM Aware website and organisations such as QISA, such as Shakti and Sahelia that support. So I do use what's existing, and I would like to be able to say this is statutory guidance. It would help me just as having a law helps me when I'm training. Even if, like what you were saying before, there might be very few times when somebody is actually the subject of an order. I can think of one time in the northeast of Scotland where it would have been helpful, but it would have been really helpful for that one family. So it might just be that being able to say this law exists, this guidance exists, it strengthens, you know, just what we say as Scottish people about this being unacceptable, and also about how best to work with communities where children might be at risk. But I think if the guidance can incorporate the experience of folk who work in this area, that it's much more often that we come across someone who's experienced it themselves than that we come across a situation of risk for a young person. So we might see someone at the subject of a lot of panic when actually they have absolutely no intention of subjecting their child to FGM, and would be absolutely shocked to think that somebody thought they might, because they see it as trauma. And I think the other thing that would be helpful in any guidance is the fact that figures can be quite unreliable. So I think in the report there was something like 24,000 folk in Scotland who were born in a country where FGM is practiced. But you'll see a lot of people who were born in France or Italy or indeed in Scotland who are from within a practicing community. So looking at somebody's country of origin is not necessarily the most useful thing. And sometimes it can be really reassuring to have definite black and white facts and figures, but other times just being open to nuance and to learning a bit more about the reality of how things play out on the ground might be a better idea.
Okay, thank you. Esther, did you want to say something about training?
I think I'll agree with her. Definitely there is need to use the guidelines and all the information we have, but above all, really incorporate what the experiences which are there on the ground, so that we can have, I think for me, is having sort of a standardized training, and also in terms of the culture, the feelings and the ways, and understanding the whole concept about the FGM, and that way then it will not be rejected when people come and they walk out of a training room, but you talked and finished and nobody had a word. I've come across a number of people. They went into a training, but they left a little bit disappointed. So you don't want that, because you've not really taught anything. And instead, people go back into their own cocoon and say, well, those people, they were speaking to themselves.
Jamba, do you have anything to add?
We deliver training on forced marriage, most of them, but just now, currently, we are developing training on FGM. But like I said, we want to do a good job of it. We want to consult our survivors and looking in, getting the real stories. And with the forced marriage training, we do use the legislation. We do talk about the legislation and the consequences of breaching a legislation, because that's very important for whoever we are training to know that. But we currently don't specifically do training on the FGM, although it's a part of harmful practices, but we don't. But when we do, we just, what Zara said, that's what we would be doing. But we want to really involve our survivors in it. And already one of our survivors is an active campaigner. She's in Gambia just now. That's why I wanted to ask her to come, but she couldn't come. And she was part of the launch of the bill as well. She was on telly and all, which was good. It was good. We like to see role models.
I would just like to add on, just briefly, when it comes to training, Quisa cannot do major training with 20,000, which we have been given. Although we have trained outreach workers, we have trained community champions, women who are within the communities, but they are constrained because what they are doing, they are going to do it on a voluntary basis. So I think when we are thinking training, we should think resourcing, the whole package, including connection to the universities, college and training. Really, it's the whole works. So resourcing.
Yeah, that's very helpful. Thank you. Thank you, Convener.
Convener, I wanted to ask, obviously the bill is a slight departure from the kind of UK or rest of the UK approach in terms of the 2015 Act, and I just wondered whether you had any views on anonymity for victims, the offence of failure to protect, and the duty to notify, and whether you think they should have been included in this, or whether you're happy with the bill as it is.
in December, January would put that in a bit more detail, and I'm conscious people have to leave. I think anonymity is helpful, or some way of preventing the names of victims from getting into the press, one way or the other.
Derek, can I just clarify, you mean your submission to the Scottish Government consultation?
Sorry.
Okay, that's
yeah.
okay,
I don't think there's anything else I could say that wasn't already in there.
We were also part of the submission, but with the group, with Scottish Women's Aid. I just want to raise one thing, that what we came across is where a woman is suffering domestic abuse, and sometimes the FGM, and she is identified as the perpetrator, in that case by either from the abuser or whatever. I think police and social work and services like that, we have to look outside the box as well. And sometimes, if you speak to the women, she is under so much pressure, and it's part of the domestic abuse that she's being through. Actually, she really doesn't want to happen that to her child, but the way she is implicated in the act. So it's just a suggestion that, you know, when you come across cases of domestic abuse where FGM is part of it, and maybe we need to look at the perpetrator. If the perpetrator is, if the woman is accused of as a perpetrator for the FGM, and yeah, that's raised by our survivors saying that, you know, we are not the perpetrators, but it's the family pressure, everything else, and that's the reason that she left the home. Yeah.
Thank you. We have heard from others. I mean, I think the committee would acknowledge the coercion around this and how it can be a continuum, and also that sometimes risk factors and protection factors and these types of things can be kind of muddled up a little bit. But thank you for that. That's really helpful. Oliver.
Just
of course.
One thing that can be helpful to social workers if they're in an area where they have safe and together model is, you know, just use the training that you already have in this context. If it's part of domestic abuse, look at the strengths that the mother is displaying and don't sort of jump to, oh, we can get a prosecution for failure to protect or something like that.
Oliver, sorry,
That's okay. And my other question was really, which you've kind of touched on with education. I guess, are there other things that the Scottish Government should be looking at to sort of sit alongside this, or as alternatives to help eradicate FGM?
In addition to education in the schools, that's the best one, I think, because when I said, you know, education should be for everybody, the reason I said, one of the reasons I said that is, you know, a disclosure might have, African child might disclose it to a mainstream child, that this is what is happening to a friend. Then if that friend knows about FGM and all, they will be able to support that child. And also, as we go on, we won't be talking about training because they're already trained from school and they know about the issues. So that's another thing. But coming back to this, also working with, like we already mentioned, working with the communities. What we do at Shakti is we have women's group, and we do bring in these subjects like FGM, sexual abuse, and all kinds of issues, somebody to come and talk to the women, and not to the African women. We want them to talk to all our women from different ethnicities, because we want everybody to know about this. So that's what we do. So again, you know, it's not just about raising awareness in the schools, but also in the communities. Women's groups, if anywhere, it can be Scottish women's groups or Irish or African or Indian. I think awareness should be for everybody and not to target just the communities where the practice is in existence.
I think I'll just add on to that, I think we need to relook again on the way that we resource or fund various organizations, including QUISA. And I think there is a lot of small funding here and there for all the community groups which you find. So therefore, we end up competing for resources, competing for the same people, and being a little bit not as organized as we should. And that also says that programs which are started are never really finishing. They start and are left on the high. We train community outreach workers, but then we leave them to do their own things. We work with the faith leaders, which we had even a whole big declaration, the signing of that FGM is not part of the religious order, whichever, if it's Islam or Christian, but then we leave it on high. We've just worked with the school children, then we leave it on high. So the community is always in this phase of, oh, we are running and we are doing something, and then, oh no, you're deflated. So I think it's important to relook at the way we fund, we are going to fund this moving forward. Working, of course, with various groups, definitely the children is important, and putting resourcing and really looking at the expertise with whichever way we look at it. That's, for me, important. Yep.
Really, really helpful and very, very interesting, so thank you.
Those points that you were making have been picked up in our budget inquiry as well, but it's useful to have them on evidence here today as well. Sorry, Sarah, did you want to come in briefly? I'm conscious we're...
Again, yeah, ongoing issue with funding for voluntary organisations, third sector organisations. It would be good to think that all bodies that would ask for training would have a budget to then pay for the training, so that we weren't having to necessarily ask for it all from a very small equalities budget, but equally if that could be increased, it would be fantastic. But I think it's good to think about ways of training people who want to look at the whole of manifestations of violence against women and girls, because I think there's a real risk that people ask because they're fascinated about one particular aspect, such as FGM, and that kind of attitude isn't, I'm not going to be able to expose someone who's experienced FGM to that environment. So kind of thinking about what training can do, and that it's not a form of entertainment is also something that's quite important.
Okay. Fulton McGregor's going to come in with a very brief question, and there'll be really succinct answers, I'm sure. So, yeah. Fulton.
It was just back to Oliver and Dale's earlier question around the issue of anonymity, which I think is a very interesting part of the discussion around this bill. I'm just wondering if you think that there's powers that the courts already have that they could use to provide anonymity better, perhaps, if that's a way of putting it, the powers that are already in place?
That's an area of expertise, so I can't comment.
Okay, thank you. Sure.
Thank you very much for being with us this morning. Your evidence has been really helpful, thank you. And we'll suspend for about 5 minutes to change panels now. Welcome back, everybody. Can I say good morning to our second panel and introduce them? We have Vicky Davitt, who's a gender-based violence midwife and FGM lead at NHS Lothian. Dr Rachel Wood, consultant in public health medicine, information services, NHS National Services Scotland. Obi Amadi, lead professional officer at Unite the Union. And Katie Cosgrove, organisation lead for gender-based violence, NHS Health Scotland. Thank you for being here this morning with us. Can I open up by asking whether you support the bill's aim to strengthen the existing legal protection, and if not, why not? And what your general view is on the existing legal framework here in Scotland, and you may want to say a bit about your own work in answering that. So, who would like to go first? Katie, thank you.
Excuse me. Yes, we do support the provisions of the bill as have been laid down. The work that we've been doing as part of the gender-based violence programme in relation to FGM is specifically around the National Action Plan and the implementation of the National Action Plan. And I chaired the writing group that produced the multi-agency guidance. So part of the work with the programme is around excuse me, ensuring dissemination of that guidance and implementation of that. In terms of the existing legal framework, I think the provisions of the bill undoubtedly strengthen the options that are available at the moment. I think they create more visibility within communities in terms of the orders, which is fairly positive, I think, in raising awareness of that. And we also support making the guidance statutory, putting it in a statutory fashion.
You don't need to press it, it's okay. Just
right, okay. Yeah, good morning. From our perspective, yes, we do support what you're proposing. We think that it should even go a little bit further in terms of clarity, in terms of, you know, a very, very clear message in terms of FGM. One of the other things that we would like you to consider is whether in terms of your legislation, if it could be more reflective of England and Wales legislation, so that we have something across the UK that looks more similar. Because again, in terms of clarity for professionals, you know, we believe that that would be of a benefit. Okay.
Probably get into that a little bit more later. Rachel.
Thank you. I don't feel well placed to comment on whether the specifics of the proposed legislation are the best way. I mean, what I would say is, of course, I support the aims of the legislation. Whether the exact new legislation that's being proposed is the best way to achieve those aims, I don't feel qualified to say. My role is within the NHS Information Services Division, and I'm the lead there, the clinical and public health lead for our national data on maternal and child health. So that's more the area of expertise that I'm bringing today.
Thank you. And Vicky.
Hi. I really can only speak from an NHS Lothian perspective, so I think I would agree with Katie that I think the existing legislation needs strengthened. I think it's really helpful that it sends a very clear message that Scotland will not tolerate FGM, but I am very much aware that I'm speaking from an NHS Lothian perspective because that's my job.
Okay. Can I ask then specifically around health, how FGM is currently recorded by health services, and if you have any views on whether there are ways that we could more accurately record to sort of help us better establish a baseline of how much FGM is actually happening in Scotland. We've heard evidence from the previous panel about how we're calculating numbers and stuff. It would be interesting to hear your perspective on that. Whoever, Vicky.
I've got my figures, but those are only the NHS Lothian Maternity Services figures. What I would say is that we need to find some way of recording. The Royal College of Midwives have launched an e-platform that is accessible to different levels of people working within FGM, as well as people from affected communities. And one of the bits on the website is figures. They have a list of services that are available across the UK, but when you look at the section that's on figures, everybody falls into the sea at Berwick because there's just a huge, well, there's just nothing for Scotland. And so that you could interpret that the FGM isn't a thing in Scotland, which we know it is. So I think we need to find some way of recording. I think part of the problem is that in Lothian we use TRAC as our electronic patient record. We can extrapolate figures from that, but I know that in Glasgow they use Badger, so there's kind of systems that are not talking to each other. The other thing is from an FGM midwife's point of view, I would not be supportive of something that's going to create extra work for people that are working within the sphere. You know, we're busy enough as it is without having to think, oh, I need to record that on a different system. But we do need to find some way of getting figures that can be as accurate as possible. I mean, I know my figures because that's the numbers of women that have been referred to me from staff within NHS Lothian Maternity Services. And I've kind of got anecdotal figures from a colleague in Glasgow and a colleague in Aberdeen, but they are very much anecdotal. So we do need to, because the more accurate our figures, then it goes back to resourcing that, you know, I can prove that I need to have my job because of the figures that we've got, but it goes bigger than that, really.
So the complexities around the different systems and not adding additional workload. Rachel, do you wanted to come in? Yes, please.
Yeah, so I think there are probably two issues to consider. One is the recording at local level in patients' full clinical notes, and the CMO obviously issued guidance in 2014 and 2016 that if a woman was known to have experienced FGM, that should be recorded accurately in patients' notes. Vicky's right, of course, that different boards use different systems to maintain those local notes. There's then a separate question of national returns. So what central returns are coming into ISD from across the health service? And it's maybe to give a little bit of context to understand. So when certain elements of care are provided by the NHS to patients, that different elements of care generate different types of records that come into ISD. So for example, when someone attends a consultant-led outpatient clinic, there's a certain return that comes into us. When someone's discharged from general inpatient care, there's a record, and there's a specific record when a woman's discharged from an episode of maternity care. And there are also child health records. They operate a little differently, and I could speak about them separately. Those national returns, if a patient, on all the outpatient and inpatient records, if a patient underwent an operative procedure during that care, then a specific code from a particular coding classification called the OPCS is added to that record. And separately, just on the inpatient records, not the outpatient records, there's a separate coding system that can be used to code the diagnosis that a patient has, so the reason they came into hospital, but also any other significant medical problems that they have. And the CMO guidance is clear that if a woman is known to have had FGM, that should be included. The code indicating that should be included on those records. So I think it's important to understand what that means, because these are coded records. The FGM or procedures to correct FGM can only be recorded on them once there's a code for that. So the codes for the procedure codes for defibrillation were introduced in 2014. So we've been able to count those events since then. And the diagnosis codes that indicate that a woman has had FGM were introduced in 2016. So we've now got 3 years' worth of data in our national data sets looking at that. So I have looked at the figures before coming today. So ISD holds these in our general, the data sets that we hold. We publish general information on the numbers of people coming into hospital. We don't publish currently specifically on FGM, numbers of women with FGM, but we can provide those figures on request. And the numbers of women being recorded as undergoing defibrillation procedure remain very small. So looking across outpatient and inpatient records, that's fewer than 10 women a year recorded as having that procedure. The numbers of women being recorded as having a history, being cared for by the NHS, either because of their FGM or for something else, but they've known to have a history of FGM, that is now at around 100 women a year being recorded on national records. So that's increased from 2016-17, the first year we could look at that, it was about 50, and now in the most recent year, 2018-19, it's about 100 women being recorded. So I think that shows us that this is now being recognised in the health service, and it is being recorded more accurately than it could be previously.
Do other panel members wish to come in on that? Or? Yeah, Obi.
I'm unable to comment on the detail of the data capture that is used by the different boards in Scotland, the different organisations. However, one of the things I would say very clearly that I would support is the national data collection, being sure that everybody understands the categories, what it is that they are recording, what it is they are reporting. Because one of the things that we've had was an issue in England was about the confusion amongst professionals about recording and reporting. So to be clear on that, I think is essential. And the training that needs to go along with that for professionals is also, quite key to this, to make sure that they are addressing the issue and addressing it properly.
Thank you, that's helpful. Katie, do you have anything to add?
I think actually the main issue is about identification of FGM in presentations, whether it's directly related to that experience or not. And I think quite a lot of our information is actually captured in recorded notes, which don't necessarily make their way onto the system. And I think it's been fairly fragmented over the last few years, but it is relatively new in terms of practice for the health service in Scotland. So I would anticipate that there'll be growing recording the ISC will be able to capture in future. I think the challenge for us is ensuring that staff are aware of that requirement, that they know which codes they should access, and that they use that accurately.
That leads me on quite nicely to my next question, just to have your reflection on whether health professionals feel supported to have discussions about FGM with women and girls that they're caring for.
There's a lot of health professionals that are covered under that umbrella. I think there are certain aspects of the health service that probably feel more supported than others because there's more focus in it, particularly maternity services. There's been a huge concentration of effort, I think, on ensuring that we can have sensitive conversations with women when they present to our maternity services around some of the implications that FGM might have for their subsequent pregnancy. I think other areas of the health service there's been perhaps less attention, and one of the issues I think that has dominated discussion over the last few years has been the child protection issue, the need to obviously prevent FGM and to protect children, which has been, I think, a little bit to the neglect of the other needs of women who've experienced FGM, because they're not just mothers. They've been through an experience that may have been traumatic, bear in mind what Sarah had said earlier, and the repercussions of that and for their long-term mental and physical well-being, I think, need to be taken into account. I'm not sure that across the rest of the health service we've given as much attention to that as we have around the need to put in place some provisions to ensure that the child protection concerns are noted and acted upon. So I think we do have a challenge in ensuring that our mental health services, for example, understand how they can have conversations with women around the impact of those procedures if it's affected their mental health, and other aspects of the health service, because there are multiple points of entry into the health service, obviously, and we know the litany of emotional and physical impacts of FGM and subsequent health for women.
Yes, sure.
Thank you, Convener. Just a very quick supplemental question on something both Vicky and Katie have addressed there. And we heard in our initial briefing from the Bill team that this needs to cover adult women as well, because after childbirth there is a possibility that that woman might be taken somewhere to have further FGM conducted on her. I just wanted to bottom out how much of a reality that statement is, and if you're aware of that being a practice, that after childbirth there might be further mutilation.
I think certainly from a Lothian perspective it's not very common, but it is something we are very aware of. We have had a case where we actually weren't concerned about the potential for a daughter that was born, but we were concerned from the mother's perspective because in questioning, she couldn't tell me why she would want to be restitched, because it's very important to us that the women know that if they have type 3 or infibulation and it's opened to allow delivery of a baby, that they will not be stitched closed, that we are not allowed to do that, and we wouldn't do that. But for the woman, we know that after her first child was born, she did go back to a country of origin and was restitched. And we were very clear that that is, you know, that cannot happen. But she couldn't answer me when I was trying to talk to her about it. And I think it goes along with what was said by the panel earlier, that we were fairly convinced that there was a lot of controlling behaviour from the husband. So actually we were more bothered about kind of that as a problem rather than potential for FGM for the little girl that was actually born.
What action you took to protect that woman when you came to that kind of realisation that...
Well, it's really difficult, isn't it? Because she's over 18 and therefore, in theory, she has a choice. But you could debate choice up, down and sideways and might never get the answer, because she would say that she is freely choosing to have that done. But if the reason that she's freely choosing to have that done is because she's worried that if she doesn't have it done, that her husband will then take another wife, which is another case that we've heard of a woman who does have infibulation and doesn't want deinfibulation because she's convinced that her husband will take another wife if she isn't, I'm trying to think of the delicate way to say this, if he doesn't get the enjoyment that he wants from her, then he will go looking for it elsewhere, and obviously that was a real concern for her.
You think we should do something in this Act to protect those women, even though they might suggest that it's their choice?
I think it would be a very useful adjunct almost to raise awareness of that as a possibility. I think there is, as a midwife, I'm kind of sitting in two camps in that I'm very aware of the child protection issues surrounding FGM, but I'm also very aware of the issues for women who have had FGM as children. So I think it would be a very useful thing to kind of bring that into the light, that actually FGM isn't all about children. We're dealing with some women who have been very severely traumatised by events that have gone on in their lives, and that needs to be recognised. So actually to include that in legislation, I think gives it credence, it gives it kudos to say, actually, this is a problem and we are aware of it as a problem. Certainly from a Lothian's perspective, it's not a massive problem, but it is something that we need to be aware of. Thank you.
Can I bring back to how professionals interact and talk with women about this, if anyone has any reflections? Yeah.
Certainly in Lothian, you're going to get very bored with me saying that, but in Lothian, I fought very hard to get this role within maternity services in NHS Lothian. I'm very lucky that my boss is very supportive of me within this role. Part of my role is working with women, and part of my role is training midwives. So we've trained midwives, we get invited, I know one of the colleagues on our team was speaking to medical students just at the beginning of August. So, you know, we do get invited to speak to all sorts of different health professionals. It's very important that health professionals are aware of the language that they use when speaking with women. I was at Glasgow Airport just a month or so ago working with UK Border Force and Police Scotland on Operation Limelight. And one of the things that I needed to say to them was, it is about the use of language. So if you actually say to a woman, do you know about FGM? There's a very good chance she's not going to know what you're talking about. Or some women actually might be really offended by the use of FGM. So it is about finding out what words the women use. What do they understand? If I say to you, female cutting, what do you understand by that? So if a woman, the woman I was speaking to yesterday, she calls it circumcision. So that's fine. With her, I called it circumcision, but it's not. Circumcision isn't something I would usually use because of the links to male circumcision, which is a whole other. Let's not even get into that. But it is important to use language that women recognise. And one of the things that we give out at our training is a little postcard that I think actually came from the Scottish Government with different words in different languages. So I know that there's 4 different words in Arabic, for example, and it is just a question of picking out which word is useful. And when I was working at Glasgow, I managed to peel from the back of my head somewhere the Somali word for FGM because they were speaking to a Somali woman. So it is about the use of language, but it's about using language that women understand. And health professionals are actually quite good at that, but they can also be quite bad at that.
Vicky, I wonder as well if in that sort of environment where you're caring for someone, you're not necessarily always asking directly, using that language. Are there other sort of routes of inquiry in terms of symptoms that people experience or different, I suppose, with something that is so sensitive, even in maternity settings, just coming out with, you know, that might be tricky. Are there ways that people inquire without?
In Lothian, we have a policy of universal inquiry, which actually reflects back to this possibility of racial profiling. So all women get asked if they have had any form of cutting or piercing that might cause problems in childbirth. You know, that might include something that somebody's had a genital piercing that's gone wrong and it's got badly infected, and that might cause problems itself. So we have this universal inquiry approach. And then if the woman gives a positive response to that, then she would be referred to me. And then I would ask questions because women often don't know what's been done to them. I work as a midwife. I am very familiar with what women's anatomy is, but a lot of women are not familiar with what a woman should look like. So to give you an example, a woman expressed surprise when I described the fact that there was 3 holes. She thought there was only 1. So if a woman doesn't know what her anatomy looks like, she doesn't know whether her anatomy is normal or not. So a lot of my work is kind of teasing out what problems she might have. So a woman might say, "Oh, I've not had very much done. It was just a little bit." But then actually, you talk to her and you kind of think, actually, you've got bigger symptoms than what you're telling me. And I know a colleague in Birmingham would describe the same thing, that women are told one thing and sometimes the opposite is actually true. So it's about finding out how each individual woman is affected by her personal experience of cutting. I can tell you what type 1 is, I can tell you what type 3 is, I can tell you whatever you want. But within that, there are women who may have been cut by a doctor, or there may have been women who were cut by an old woman who doesn't see very well and just is doing whatever she thinks. So there's kind of, you know, the categories are kind of useful, but only up to a point, because it is about the individual woman and what her symptoms are.
I wonder, do you have any reflections from a health visiting perspective on those?
Yes, I do. I mean, in terms of the issue of FGM, I mean, we found that often health professionals feel uncomfortable in terms of broaching it, which is why having a universal approach to it is the one that is favoured, so that everybody is included, everybody's involved, everybody is asked. Some of the concerns around, you know, with some health professionals in terms of having to then begin to have those conversations is about, you know, pressure on time to get everything done. So, you know, we recognise that there needs to be kind of cooperation for something like that to be successful. But it is important. It's really, really important in terms of the input into schools and to ensure that, you know, the health professionals' conversations and their asks, it's boys as well as girls. Because, again, a lot of the time, the focus is so much on women and girls. People forget about men and the role of men within families and within the communities. So for health professionals to be speaking to everybody about it is definitely of value. apart from the kind of like the work pressures, people also feel uncomfortable in terms of will they be viewed as being racist by raising this with women who, as we say, we know the majority of occurrences are around the African continent. To not do it would lead to the question about what people's views are and whether or not they were racist. It's you know, it's very clearly something that should be done. It's very clearly something that is of value. And until we have a system where that operates and where professionals feel trained, competent and confident to do it, there will always be people who will doubt it. I mean, in previous years, I mean, people felt this way about domestic violence and they didn't want to ask it, they didn't want to broach the question. Now, professionals are much more comfortable with doing that and it's routine. That's where we need to get to with FGM.
Thank you. Can I move on to Mary Fee?
Thank you, and good morning, panel. Given what you've said about the guidance, and I take it you all agree that it should be statutory, the guidance should be statutory that's attached to this piece of legislation, is there any specific piece of information that you think should be included in the statutory guidance that would assist health professionals in dealing with women and girls who have either had or at risk of FGM?
Quite sure I can think of any particular gaps in it. I think moving on to a statutory basis would give it more weight, obviously, amongst professionals. It would ensure that it's got wider reach, I think, than possibly it has at the moment. I think the issue about speaking to women around abuse could probably be highlighted within the guidance. When we were pulling it together, we consulted with women from different communities around the language that we used in the guidance, but also how they wanted us to reflect the way that they wanted to be spoken to about FGM. And not just in terms of whether you call it cutting or circumcision or whatever, but more around the atmosphere in which you would ask about it and the circumstances in which you would. And I think it's really important that it's highlighted as important health information coming from a health point of view, that it's not asking it on the basis that you're African, so we just want to know whether you've experienced FGM. It's much more around, has this had an impact on your health? If so, what? Is it affecting your presentation here today? Will it affect your pregnancy? Will it affect your mental health or so on? And what can we do to kind of mitigate and ameliorate those circumstances? I think possibly the strengthening of the guidance into the statutory basis might give it more of a focus in those other areas of the health service out with maternity care, you know, because we do see a preponderance of focus there. All of ours, or most of our stats come through maternity services in relation to FGM, but we know that women are using all our health services. We're just not seeing that reflected in the stats, which suggests that either there's a very good clinical and health service response, that it's not required, or that we're not having those conversations across all the different domains in the health service.
Does anyone else want to add anything to that? Perhaps then, Vicky, I could ask you a specific question in relation to that, because I was quite struck by what you said about being at the airport and with the border force and the different language that's used by different communities to describe and to talk about FGM. Is the different language and the different words that are used, is that already in the multi-agency guidance? And if it's not, should that be included in the statutory guidance to help all the different agencies when they come to talk about this?
All I can say is, so we've got a multi-agency guidance in Lothian, and then there's the national guidance as well, which I don't know as well as the Lothian guidance, because I was on the working group that put the Lothian guidance together, and there is a glossary at the back that of all sorts of different terms that might be used in lots and lots of different languages. I think it's at least 1 page of A4, if not longer, because, you know, if I'm talking about female genital mutilation and female genital cutting or circumcision, well, that's 4 different things I've said already. But then within that, you have labial elongation and even down to something as simple as, what do you mean by piercing? Because piercing can mean something like having your ear pierced, so you have a hole and then you put something in, or piercing can just be a hole is made, and that's one of the, you know, the potentials for type 4. So I think the glossary certainly is in our guidance in Lothian. I'm assuming it'll be in the national guidance as well. So therefore, it's not going to do any harm to put it in government guidance so that everybody knows what they're talking about.
And is the guidance something that you would use in training?
Yes, I think which has already been said this morning, having guidance from government gives everything more weight, so that when we're training, we can say, look, this is the law, this is what you need to do. And certainly when I'm speaking to women, I'm very clear that the women are always told the legal position in Scotland, and that's backed up with the Scottish Government leaflet. So all the women are given that. Whether they know the law, whether they express protective views or not, they are all told the same thing. And it's the same when I'm training. Everybody is told the same thing. So if we've got the law, then you can't argue with that. That's how it is.
Okay, that's very helpful. Do any other panel members have anything they want to add?
Confirm that, yes, there is an appendix in the national guidance that covers those terms. I think, however, health staff are very unlikely to learn those different terms. There's the multiple ones. I think really the point of flagging that up in the guidance is just to ensure that staff are aware that there isn't one term that you could use. But I think the other thing that's come across very much in the work that we've done with women is that routine inquiry of any form of abuse has to be couched in such a way that it makes sense to the person that's been asked about it. And what we would want questions of this nature to be couched in is language about, has anything happened to you that may have caused you hurt, that may be causing you problems just now with your health, or that you've got concerns about, or in the case of pregnancy that might make it difficult for you to have a smooth and uninterrupted labour. So I think the way in which the topic is broached is much more important than understanding, you know, the 30 odd or 40 odd different terms that they have across different communities for that particular procedure.
As I understand it, the multi-agency guidelines are primarily focused on advising and guiding around the frontline staff around the identification of risk or actual FGM and responding to that appropriately. I suppose I'm responsible for what comes after that. Once it's been acknowledged and recorded in someone's notes, then there is the issue of getting it accurately coded onto national records. And ISD is responsible for producing the national guidance for health records departments on exactly how to code things. And that we did produce guidance. That guidance exists in response to the CMO letters of 2014 and 2016. Our national terminology team produced guidance for all the health record departments across Scotland on how to code. If it's identified by the frontline staff and appropriately recorded in the woman's notes, there is guidance on how it should then be recorded in the national returns. I think that's probably separate from the multi-agency guidance that you're talking about.
Okay, well, thank you. Obi, is there anything you wanted to add?
No, not at this point. I mean, I think that I agree with my colleagues.
Thank you. Fulton.
Thanks, Convener. I want to ask the panel a question I asked the last panel as well. It's about the children's hearing system, and whether any of the panel members think that the children's hearing should be able to grant an FGM order.
Comment on that.
I'm not sure. I think on the one hand it may be seen to expedite matters a bit if they had that power. I'm not sure that it would necessarily change the situation greatly. You know, they have powers obviously in relation to compulsory supervision orders. Very often cases get referred from the Children's Panel to the Sheriff Court anyway, and I think in seeking an order of that nature, I don't think that there's any huge detriment to the case that it comes through the court. But that's just a personal opinion.
Yeah, that's fine.
I don't have enough experience in children's hearings and things, so I would agree with Katie.
Okay, thanks. Thanks, Ben. Oh, sorry, Obi, I didn't see you.
Yeah, sorry, I'll get confused with it. I mean, I think that in terms of anything that will expedite, anything that helps clarity, is something that should be pursued and introduced. So if that will be more helpful to professionals in the system, then that should be something that should be considered.
Okay. It's an area that we've explored at previous evidence sessions, just to get a sense for what people think about that particular issue. Can I ask a wee bit about what your view on the criminalisation of the breach of an FGM protection order is, and do you have any views on the penalties that have been set for a breach of FGM?
Tell you what the women say. So as I've just explained, all the women that I see, I explain the legal position, and more often than not, when I explain, the custodial sentence that is a potential, many of the women will say that's not long enough.
Okay.
Not qualified to comment on that.
I can't comment on that.
Okay. So go back to your answer, Vicky. Some of the women that you're speaking to, do you feel that do you feel that the penalties need to be more? Need to be.
That's the opinion of the women who are survivors of having had it done to them. They are very much of the opinion that they wouldn't want it. They want the practice to stop, and they think that one of the ways that the practice will stop is actually much tougher sentencing. I think the difficulty we have is, of course, there's only actually been one case in the UK. Until we have more evidence that of how the courts are going to treat this, I think it's very difficult to say. We haven't got the evidence to back it up. The one case, the woman went to jail for, I think, 12 years. So, it was taken very seriously. But is that going to happen in all cases? We don't know until it happens. But I think it sends the right message that Scotland is taking FGM very seriously. And if you're caught, then this will happen. And I was speaking to a lady yesterday who, she said, well, I know that if I did it, I would go to jail. So that, the message is out there that it is taken very seriously in Scotland. And I think that's really important.
And that's really interesting to hear that direct experience that you've got there working with women. But we actually heard on the panels last week, for example, a fear that the criminalisation process and perhaps the tougher the sentence, if you like, that it could lead to forcing the practice more underground, and that was a fear that was expressed as well. So it almost sounds like there's a real balancing act there between these two. Is that something that the panel recognise as an issue? I
would agree with that, definitely. But on the one hand, you've got women saying that sentence isn't long enough, but we also know that those are women who are already quite vocal in the fact that FGM is wrong and needs to stop. But then you do have the potential for families or communities that are still practicing FGM, that you do have the potential that it will go underground. Just because I say to women, look, FGM is illegal in Scotland, that doesn't mean it's not happening. We know that murder is illegal, but murder still happens. So I think it is a very delicate balancing act, and I think the difficulty is getting the right intelligence from within the communities, because one of the things that women are told is that you don't talk about FGM. So if it's not talked about, how can you find out if it's being done? And that's a really difficult one.
So, I mean, in terms of the custodial sentence, the anecdotal information we've had from women is, yes, that they do want a custodial sentence. That term, I mean, I can't, support, or advise a particular term. However, in terms of the effect that it will have, again, it will send a very, very clear message to perpetrators that this is something that is a crime, it's a criminal offence, and from that, I think the fears that people then have about it going underground, it's already underground. If there was a shop you could go to for FGM, then we'd know it wasn't underground. It is already. But if we work with the communities, if we work with the professionals on this issue, because I mean it's one of those things where you can't do it in isolation. There needs to be a much wider approach in terms of educating people and supporting them. There will be less opportunities for an underground system of practice to actually happen and to thrive, and that's one of the things that we need to think about in terms of all the stuff that is going on behind the scenes. We need to think about how we work with the communities, and the communities and the leaders within communities are key to this in terms of eradicating or reducing its occurrence, because again, as my colleague said, there are other things which are criminal offences and they still continue, but to be able to make a big impact on that, we need to make sure that the involvement of others is right.
Okay, thanks, Kavita.
Oh, you mentioned in your opening, obviously we have slightly different systems in England and Scotland, and I'll ask you this question first, then open it out. What lessons can we learn from approaches that are taken there? Are there things that that are working well, that are not proposed in this legislation, or things that we've missed, perhaps?
Well, one of the things that if I tackle one of the most difficult ones maybe first, is about mandatory reporting, which has been controversial, has been kind of unpopular maybe in England. However, some of us view it as something that is quite successful in terms of the fact that it has allowed or enabled the professions to be very, very, very clear on the whole issue of FGM. It has allowed professionals to be clear about the fact that if somebody says that they have had FGM, it doesn't, because again, we had a situation where some health professionals would feel that they needed to examine that woman or that child to have a look, and that is something that is completely inappropriate. That is something that needs to be left to the professionals who have the specialist knowledge. And because of that, it has led to the growth and the increase of having specialist roles around FGM. I mean, there were always some specialist midwives who worked around FGM, but that number has increased. And amongst other professional groups, they are starting to have more people who have that specialist knowledge, because it is something that, in terms of identifying and confirming, is quite specialist. And
one of the opinions that was given to us, now forgive me, I can't remember if it was a panel or if it was one of our visits, was that the mandatory reporting could be harmful to relationships, and while people would never collude in the practice, that mandatory reporting might be damaging for communications. How would you address that?
Yeah, see, I don't agree with that. And I know, again, in England, one of the things that we had were a lot of GPs were concerned about their relationships with their patients, if that was an issue. I think the things that happen in a GP practice are quite important, because sometimes, whether it be the practice nurse or the GP, they are seeing clients who are coming repeatedly with backache or with urinary tract infections, and aren't always necessarily thinking, oh, these might be triggers to have another conversation, which is why universal asks are so much better. If you are open and honest, if you have a relationship, because a lot of the success in terms of dealing with issues like FGM, it's relational. So if there is a situation where you have trust, you are more or less likely to have the issue of a deteriorating relationship, because if you're honest and if you're very clear about what is going to happen and why it is that you're doing and saying what you have, just like in other child protection safeguarding situations, I think that there is less chance that that is an issue.
Bring other panel members in if they have an opinion on the mandatory reporting at all.
Yes, I think first of all we need to be clear about what type of mandatory reporting we're talking about, because health professionals in England are obviously under two separate duties for mandatory reporting. There's, first of all, they're under a duty to report newly identified case or any case of FGM that they come across to the police if it's a child, for children. But also then there's the separate mandatory duty that they're under to report identifiable information to NHS Digital. So that's NHS Digital would be roughly the equivalent organisation to ISD in within NHS England. So I think you're talking here about the mandatory reporting within the health service. And ISD is clear that we would not support that in Scotland. So I'm going to respectfully disagree with my colleague on the panel. There is no mechanism. There are established mechanisms in England to mandate returns to NHS Digital. That's because the Secretary of State is working under different legal powers and those we really don't have those mechanisms for a start in Scotland. Obviously, some reporting, some health events are subject to statutory reporting, but they're subject to very specific laws in and of themselves. So like reporting of terminations of pregnancy to the Chief Medical Officer, reporting of notifiable infectious diseases under public health legislation, for example. But there's no mechanism currently for ISD to mandate an identifiable return on FGM. So I think there are practical issues why we wouldn't support it. We would support, I think we would prefer, my personal preference and organisationally our preference would be to really support the accurate recording of FGM as it's identified in the routine records that already come in. And as I've already said today, I think that is strengthening and we are starting to see that coming through from the guidance that's already available. And I think there are wider professional issues around mandating, and I do have concerns about how it influences the relationship between health professionals and their patients. I think it potentially puts doctors in conflict with their professional duties from the GMC, where we always have a duty to make the care of that individual patient our primary concern. And if you're under separate mandatory duties that take away your clinical judgment as to what that patient's best interests are, that can be a very uncomfortable professional position for doctors.
Okay. Does anyone, I'll let you come back in, Obi, if you need to, but did anyone else, Vicky, you were looking like... No, or Katie?
Sorry, Vicky. I would echo what Rachel said. Certainly when we were developing the guidance and we had considered some of the issues around the mandatory reporting that they have in England, it was very much about how we have a proportionate response and how we ensure that we can support health staff to identify and respond sympathetically to women presenting with FGM and ensure that that confidentiality was maintained. I think the concerns that were raised by women when we consulted with them was that they wouldn't feel that they had any control over that information. They weren't sure what was happening and they didn't make the distinctions necessarily between what we were doing and what was being done internally within the health service and externally with the police. And part of the concern was around what impact that might have in the relationship with the practitioner. So there is clear guidance on how we share information across the health service, and at times obviously that's very important. But I think the concerns that were raised both by women and practitioners, because there's been quite a bit of disquiet, I think, about the nature of that reporting among some practitioners in England, certainly shaped our thinking in terms of not supporting that in the bill.
Okay. There are a number of articles I could point you to where health professionals are expressing serious disquiet about the mandatory reporting requirements. And also, ironically, it doesn't necessarily lead to good information. You can mandate it, but actually NHS Digital continue to publish their statistics as experimental, and there are concerns about the quality of the information that's being generated.
It's always helpful to the committee to hear differing perspectives. Vicky?
I think one of the things is, what are we actually trying to achieve by mandatory reporting? I think the system as it is wouldn't cope with mandatory reporting being introduced. I think you risk criminalising women who have had something done to them. You know, who are we actually trying to get to here? Are we trying to give a woman who was subjected to FGM as a 5-year-old child? Are we trying to give them a criminal record. And, you know, when I talk to the midwives about mandatory reporting and I say that it includes tattoos, well, there's kind of general hilarity because, I mean, we've all seen 17-year-olds with tattoos that, all right, legally they shouldn't have them, but they have. And are we then going to give these girls a criminal record because they've chosen to go and get a tattoo, which is completely different to a 17-year-old that was subject to FGM when she was 5. The two things are not the same. So I think, again, I would respectfully disagree with my colleague that mandatory reporting is not the way to go.
I wonder if I could just make a final comment on, I think Vicky's point is really important. What are we trying to achieve through mandatory reporting? I assume we're trying to achieve better visibility of the prevalence of FGM within the Scottish population, so we can plan to meet the needs of those women appropriately. And I think, as I said, I think there are better ways that we can do that through the NHS routine records. But also, I think it would be interesting for the Scottish Government to consider commissioning some research into the prevalence of FGM, because there's actually very little, well, there's none, for the Scottish population, and that's a positive thing that could be done.
Do you wish to come in?
Yes,
in your supplementary.
Just very briefly, I think this is a comment, but it's also a question as well. In terms of mandatory reporting, and your points there, Vicky, about the tattoo example, I think it's a point very well made. My interpretation of where we are in terms of mandatory reporting is more about the protection orders rather than a criminal record or things like that. So, for example, when you're talking about the woman that you assisted who'd given birth, who talked about getting restitched, or whatever it was, that if there was legislation that would then, you could lean on to protect her and have a protection order imposed on her, so that, for example, she had her passport removed until such time as it was not felt she was at risk, so she couldn't fly back to a country where this could take place. That's not a criminal record, but it is protecting her. How do you feel about that kind of scenario? And having an obligation for you to report that concern?
I think the two things are not necessarily the same, and I think it's very difficult if you are going to take the passport away from somebody. When do you decide that the risk is no longer there? Excuse me. My colleagues and I in the Al-Nisa service in Lothian, we work on a continuum of risk, that the risk never goes away, the risk is always there, it just, you know, it just changes over time. So at what point would you give this woman a passport back? And are you really going to prevent her from going back home to visit her family when she may or may not be at risk? And actually, if she's over 18, again, it goes back to choice. And for a lot of the women that I see, their body works how their body works, and that's how they like it. I've seen one woman who's had 2 pregnancies, so she's been through my system twice, but I've also had discussions with her twice out with pregnancy. So that's 4 interactions I've had with this woman to talk about defibrillation. She doesn't want to have defibrillation done because her body works how her body has always worked. And actually, it's a husband that's trying to persuade her to have it done, which is a bit different, but she's just not interested because my body's fine, thank you very much. I don't want to change how it works. So when are we going to stop? For women over 18, when do we decide somebody is being coerced into having something done, or whether actually she wants her body back to how it was, which is what all women want after they've had a baby. But it just depends on what your meaning of that is.
I think that's the challenge before us. Thank you, Convener.
Sorry, I'm just going to bring Obi back in there. I realised that we...
I did say this was a controversial one, didn't I? I mean, I think that just to make kind of like 2 additional points. I mean, in terms of, you know, what my colleague said about, you know, doctors finding it difficult. Doctors are the same as all other health professionals, and it should be it's not different for them than it is for other people. If they have the information, if they are clear, it's not an issue in terms of deteriorating relationships. You know, we don't believe that, and we've not seen that. Also, the other thing to remember is that for many of the survivors of this, when you have conversations with them, they want to speak, they want to tell, they want to be asked, they want to share, because they don't want it to happen to other women and girls in particular. also in terms of criminalisation, I mean, we're talking about the mandatory reporting when it's children. In terms of adult reporting, that's more along the lines of the recording, I would say. Yeah.
Rachel, sorry, did you want to come back
Yeah,
in?
it's
Are you
fine.
okay if we...
Yeah, well, it's fine.
Okay. Is everyone content? Okay, well, thank you very much for coming this morning and for your evidence. It's been very, very helpful. And as I scrabble for my papers, our next meeting, we're going to take evidence from third sector member organisations, regulators, inspectors and third sector equality organisation as part of our scrutiny of the Scottish Government's budget for 2020-21. And we'll now move into private. Thank you.